you see benign features here? I would say yes, 100%, many, prevalent. What? First, these pigmented lines, what are they? These are pigmented scales. You agree with me? Huh? Pigmented scales, okay? And then what about the follicles? Are they white? Yes, they are very white. Huh? So white follicles, many, pigmented scales, many, and a little bit of background erythema. So what more? PAK, pigmented actinic keratosis. Do we care if there is a little bit of gray color? For example, here, no, we don't care. We care only if the benign features are not prevalent. Then we care. Okay. Look how ugly is this lesion overall. The overall gestalt of this lesion is very asymmetric. But if we look for benign features, do you see benign features? I would say yes. Plenty of rosettes. Do you see them? Plenty. Background erythema. And again, what are these pigmented lines? Nothing than pigmented scales. So again, pigmented actinic keratosis. Okay. Of course, this is a very ugly lesion. So if you do a punch biopsy anyhow, it's not a problem. But we know now that most probably this lesion is not melanoma. Most probably this lesion is pigmented AK. Here, very easy, strawberry pattern, non-pigmented AK, okay, white follicles and reticulation, reticular vessels. Do you see benign features? Yes, of course, prevalent. Parallel lines, fingerprints, all over the lesion. Therefore, nothing. We can do cryo, we can do whatever we like. Do you see benign features? Plenty. White follicles a little bit, but especially parallel lines. Sometimes, very often, lesions on the face are combining together. Okay, so this is a little bit the problem sometimes. If, like in this case, two benign lesions are combined together, pigmented AK and solar lentigo, well, pigmented AK is not a completely benign lesion. We know that it's a kind of a carcinoma in situ, but just 1 out of 300 AKs are developing into invasive squamous cell carcinoma. So it's almost benign, let's say so. But the most difficult situation is when a melanoma is combining, for example, with a solar lentigo. Then it could be troublesome. It could be problematic sometimes. Anyway, this was a solar lentigo because of the parallel lines prevalent within the lesion. And this is what? Again, benign lentigo. What we can see? Reticulation. Okay, so very easy. It's a solar lentigo. And again, also sharp demarcation of the pigment around the follicles. This is typically seen in benign lentigos. Okay. Do you see benign features? Yes. Sharp demarcation and fingerprints, reticulation, reticulated brown lines. Do we care about this little gray color here? No, we don't, because the prevalent features are pointing out to a benign lentigo. So this could be areas of melanophages of a kind of lichenoid keratosis. You know that lichen planus-like keratosis are usually regressive solar lentigos, sometimes regressive actinic keratosis. Of course, when the regressive features are predominant within the lesion, then it's a problem because sometimes we do biopsies for of lichen planus-like keratosis, but you know, this is part of the game. Okay. Do you see benign features? Yes, I would say sharp demarcation, very sharp demarcation at the periphery. So this is completely benign. And here, if you look carefully on the top of this lesion, we see comedal-like openings. Okay. So again, lentigo, solar lentigo moving into a seborrheic keratosis. We go back to the lady I showed you at the beginning. I told you it's a melanoma, and we, like me, we all are surprised that how can it be possible this is a melanoma. But now if I ask you, do you see clear-cut benign features? The answer most probably is no. No sharp demarcation, no white follicles, no erythema, no reticular lines, no reticular vessels, no nothing. Nothing of the benign features. And now that we don't see clear-cut benign features, now that we are more suspicious, maybe we start looking at noticing these little gray areas, gray circles, gray lines, gray circles. Therefore, now that we know that this lesion could be suspicious, then we increase our, let's say, our searching power. You know what I mean? So our eye is more attracted to the small, by the small things. Okay. So, at the end of the day, in my view, lentigo maligna melanoma, facial melanoma is not a problem at all because, as we said at the beginning, in general, lentiginous melanoma and in particular, lentigo maligna melanoma is a very slow growing lesion. So biologically, is lazy. Biologically, is very slow. Therefore, we should not be concerned about lentigo maligna. The problem is the diagnostic problem. So the problem is that when we have a lesion that we don't know what it is, we have to stop and think. We don't have to do a cryo. We don't have to do a laser treatment. Okay, look at this lady. When she's 51. Definitely, it's clear cut that this lesion is a lentigo maligna. And look how long took this lesion to become like it was when the lady was 51. At least 20 years, at least. Because when she was 30, the lesion was already there. Can you see that? Can you see it? I'm not sure when she was 22, definitely I'm not sure, but as a matter of fact, this lesion took 20 years to become clear cut. Okay, so but no cryo. That's the point. Okay, and the general concepts I shared with you were the following: facial melanoma might be difficult. Patients come for cosmetic reasons. Remember to forget the age of the patients. Since early lesions do not show malignant criteria, first we have to look for non-melanoma features. And when you don't find melanoma features, we have to pay attention. And very often, by paying attention, we see the small clues that early melanoma can show when very subtle at the beginning.